So we're going to talk about what is an ethics committee and what do they do. So we'll go ahead and get started. As always, I do have your objectives listed here. So, healthcare ethics committees. What is an ethics committee? An ethics committee is an advisory board for the healthcare system that works to provide educational and consultational services to patients, families, and care providers. These ethics committees, a lot of them came about in the 1990s because the Joint Commission mandated that healthcare organizations needed to have some way to process and address ethical issues. The Joint Commission did not mandate that this needed to be an ethics committee, but most healthcare organizations did find that an ethics committee was a very effective method to fill this requirement that the Joint Commission had. And ethics committees, when they first were introduced, were very different than what they are today. When they were first introduced, believe it or not, ethics committees, as our book discusses, were called God Squads. In other words, these committees were the people that were deciding who got hemodialysis because there was a shortage of dialysis machines. And if there was a shortage of equipment, which patients should get the equipment. And so it was really about prolonging life and whose life should we prolong. And in this day and age, ethics committees not only have those type of questions to grapple with, but we're going to look at some of the complexity of the questions that ethics committees deal with. We've already talked about questions at the beginning and ending of life, and this week we're going to look at questions regarding technology and health information management. So, why do we have ethics committees beyond the Joint Commission saying we need something in place to address ethical issues? The purpose of an ethics committee is to facilitate discussion and consultation on ethical issues that arise within the patient care setting. The purpose of an ethics committee is to enhance the patient care team relationship or the family care team relationship. So the ethics committee is someone that can be sought after by the patient, by the family, or by a member of the healthcare team. Their goal then is to improve patient care and patient care outcomes through the recognition of the needs, interests, and the rights of each patient and each participant in the care delivery team. So not only is the ethics committee there to help protect the patient, but they're also there to help protect you as a healthcare professional. So if you are in a situation that you feel is unethical, they can be a resource for you just as much as they can be a resource for a patient or a family member struggling with a decision. Their goal is to cause the least pain and provide the greatest benefit. And you may be thinking, wow, this sounds really utilitarian. And you will see a lot of utilitarian and Kantian theories come out of our discussion this week. What types of dilemmas do they address? They address dilemmas related to morality, to patient autonomy, as well as to legislation. And I thought I would share an example of when I had to contact an ethics committee. I, for a very brief time, worked in employee and occupational health. And one of my roles in that job was to deal with bloodborne pathogen exposures, which were employees that were exposed to a patient's blood or other bodily fluid that could transmit disease. A lot of needle stick injuries. And what happened is we had an employee who was exposed to a needle stick injury during a code, which is a cardiac or respiratory arrest. Usually when something like this happens, we test the employee's blood and then we get consent from the patient to test their blood for hepatitis B, hepatitis C, and HIV. It's done confidentially and free of cost to both the employee and the patient, but the patient has to consent to having their blood tested. If they do not consent, then we test baseline blood on the employee, and then we do follow-up blood on the employee at 1 month, 3 months, and 6 months to see if they've contracted any of these diseases. In the case with the code, the patient died during the code, and therefore there was some pushback on me that I should allow the blood from the deceased patient to be allowed to be collected for this purpose. And I was concerned about this from an ethical standpoint and a legal standpoint because I did not have consent, and I did not find it appropriate to call the grieving family of this patient. And to add the complexity of it, it was a trauma patient from an accident that was a very unexpected event that occurred, and it was a younger patient. So this wasn't somebody, not that it would make a difference, but it wasn't somebody that even the family was expecting to die. This was a very sudden, tragic event that happened, and I said that at their time of grief, the family did not need me calling, asking for permission to draw blood from the newly dead individual. And there was a lot of kickback. And as the person who authorizes and placed the order for the blood draw, I refused to place it, and instead I called the ethics committee. And I got the ethics committee involved because there was argument of doing implied consent, and I did not feel implied consent was appropriate. As I discussed, contacting the family was not appropriate. And in my opinion, if the blood was drawn without consent, it could be considered mistreatment of the newly dead, or mistreatment of a corpse, depending on where you read your literature. And so the ethics committee got involved, and it did kind of get ugly. There was not an agreement on it, and actually, against my better judgment, there was one member of the ethics committee who did feel that they should call the family, and the family got called. But from my standpoint, I felt like I was supported in the sense that I was not making a decision on my own. They did not force me to do something that I was morally opposed to do. Somebody else took that over. And while I may not agree with what the outcome was from my beliefs, I at least had someone to turn to when I was pushed and asked to do something that I did not agree with or that I did not think was ethical. So I hope that kind of gives you a brief example of what an ethics committee is and when and how they can intervene for you. For patients, a lot of times they will be called to help somebody with a living will or an advance directive, or if there is somebody who the family is not sure how to proceed with their care and there is no living will or advance directive, the ethics committee may be called in as well. They also can be called in to do education for groups of patients about developing living wills, about developing medical power of attorneys. That's a lot of what you see them working with as far as education is around end-of-life decision-making. And sometimes they'll provide very general information about different ethical theories and principles and decision-making. So just to kind of give you an overview. As important as it is to know what an ethics committee is and does, I do believe it is equally important to understand what an ethics committee is not and what an ethics committee does not do. The ethics committee does not replace the patient or family and care team relationship. They are there to help enhance the relationship. However, they do not become a middleman between the patient and the care team. They are going to work collaboratively with the patient and the care team. They do not have surrogate decision-making authority. So that being said, the ethics committee does not have the ability to make these decisions regarding patients that can't make a decision for themselves, or where the family does not want to make a decision. They can help guide people to decisions, and they do help guide policy and procedure development and guidelines. They review policies and procedures for healthcare organizations. However, they don't have that surrogate decision-making capacity for individual cases. Similarly, they are not the decision makers. The ethics committee is not who's going to say what should or what should not be done. In my case, I would say they might have overstepped those bounds a little bit in the decision that ended up being made, but they did work closely with the provider who was treating the employee that had been exposed to blood to make that decision. So the ethics committees were a resource that helped others through the decision-making process. And in my case, it did bring to light more information about how the newly dead should be treated, and about what is considered appropriate care and what is considered to be violation of the rights of the newly dead, and what if blood had already been drawn for other purposes but wasn't needed? Could we have tested that? It brought up a lot of new questions that the ethics committee then started to look into. So while they're not decision makers, they are a great resource, and they can help guide policy and procedure and recognize from events where policy and procedure may need to be put into place. So what does an ethics committee look like? Structurally, the ethics committee should be a multidisciplinary team of individuals who all have high levels of skill in conflict resolution management. Because as an ethics committee, a lot of what you are doing in addressing an ethical dilemma is conflict resolution. That being said, you want representatives from both the healthcare system and the community. A lot of ethics committees will have healthcare system representatives from the physician group and advanced practice providers, from nursing, from social work or social services, especially healthcare organizations that have a religious affiliation will have a member of clergy on their ethics committee. And there has also been a push to have members of hospital administration on an ethics committee, because the members of administration are the people that are really running the organization, and they're who the committee is going to need buy-in and support from so that the committee can function in the appropriate ways. And an excellent way to get buy-in and support from leadership is to have a member of leadership on the committee itself. There are also representation from the community. And a key with this is you want community members who are not connected directly to the hospital. So you don't want a community member who also works or volunteers at the hospital, or has a significant other who works or volunteers at the hospital. Or usually you don't want someone who's a retired member of the hospital. Community members that often are looked for to join an ethics committee are going to be people in the community that are very involved in the community, understand the sentiments and the needs of the community, are well respected within the community, and people who have a background in ethics. So if there's an ethicist in the community, they may be called upon to be part of a committee. Sometimes an ethics professor or a philosophy professor may be called in to be part of a committee. They also like to include people that do have some healthcare knowledge and background, but again are not related directly to the healthcare system. And they may ask people, especially if the hospital does not have a religious affiliation, they may have representatives from different religious groups or different cultural groups to better understand the dynamics of that community, with the idea that the voice is heard of the community and the needs of the community and the culture and religions of the community are taken into consideration when making ethical decisions. The structure of the ethics committee is very similar to, or should be very similar to, a structure of committees and clubs that you may actually be part of on campus, where the roles are for a certain amount of time. They're termed to be a member of a committee for maybe 2 to 3 years, but not everybody's term ends at the same time, that there's staggered endings of terms, so that you always have somebody more experienced on the committee and then new people coming onto the committee to bring new ideas, but also so that there's somebody still there who understands the way that the committee should be run. The committee is going to develop policy and procedure guidelines. So there are a lot of policies and procedures, especially in a healthcare system, that are dealing with things that could be considered the rights of an individual that need to go through the ethics committee. When I worked in employee health and we were doing all of the new policies and procedures for employees regarding COVID-19 vaccines, all of that documentation had to go through the ethics committee. We worked very closely with the ethics committee for how to appropriately have exemptions for vaccines and what was appropriate and what was not appropriate reasons. And a lot of the ethics committee was sought out a lot during that time. The ethics committee was used very heavily during COVID in general about how to respond and how to handle limited resources and staffing and closing down rooms and providing treatment to patients. The ethics committee, as I briefly discussed, also provides education for the community and for staff. A lot of times, education is focused around issues such as writing a living will, writing your advance directives, having a power of attorney. There can also be more general education for staff of how to recognize an ethical dilemma, what to do if you have an ethical dilemma, considerations to think through with a dilemma. When should you contact the ethics committee? And then they do specific case review and consultations. Anybody who has worked in healthcare, you might have heard the term morbidity and mortality report. And these are reports that with patient death, and there are certain situations where patient deaths have to be reviewed by a team when death was not expected as the outcome, to see if there was anything that went wrong that should have happened differently. And a lot of times the ethics committee will be involved in those kind of cases. My situation where I called the ethics committee would have been considered a consultation because there was a very specific issue that I had a question about. Challenges for healthcare ethics committees. So, in general, what are the challenges that these committees face? And ethics committees face a lot of challenges, and that's why it can often be hard to find good personnel who are willing to join an ethics committee and who are qualified to join an ethics committee, because many people feel incompetent to join such a committee because of both the depth and the breadth of knowledge that you need to know, as well as a background in understanding some general healthcare terms. So, ethics committees address ethical issues that go beyond patient care. And while most of these issues connect on some level to patient care, in this day and age, most of the issues are not as straightforward as do we withdraw life support? And not that those are straightforward, But the committees could really say, this is what we focus on. We focus on allocation of healthcare resources. We focus on end-of-life decision making. But as we're going to learn about over these next few weeks, the issues that committees have to address are so broad. There's technological concerns, there's financial concerns, there's spiritual concerns, there's biological concerns. And so really, you need a knowledge that addresses more than just a basic understanding of human development and life cycle. Another challenge is this shift in healthcare from treating the sick to preventative care and population health. Historically, healthcare was about treatment and cure for the sick and injured. And now healthcare follows more of a population model, and this model of primary, secondary, and tertiary prevention of what can we do to prevent an event from happening. Primary prevention. Things have started to happen. What can we do to prevent it from getting worse? Secondary prevention. And then something significant has happened. What can we do to rectify it and prevent it from happening again? And that's a tertiary prevention. So we're trying to, instead of treating the ill, we're trying to keep people safe and healthy. And that shift in focus is a shift in mindset that people have to adapt and develop. And additionally, there's these challenges of providing advice on the evidence of evidence-based practice and new and evolving technologies. So there's really this level of commitment to knowing what is best practice, what is going on with these new technologies, what are the nuances of this. So there really is a commitment not only of your time, but of your ability to stay up to date on different types of information. So I've been talking in a lot of broad generalities about the challenges that healthcare ethics committees face. So I thought it might be helpful to highlight some examples of these challenges. One of the big challenges that healthcare ethics committees are facing is the quality of care that needs to be provided to the baby boomers. And this is referred to as the 2030 problem. And the concern is that will there be enough care available for the baby boomers starting in 2030 and for the next 30 years. What's happening is when the baby boomers after World War II were all born, there was this influx of people, and a large portion of them went into jobs working in healthcare. A lot of nurses, if you pay attention, are from this baby boomer generation. And there was actually a time where nurses were what we call a dime a dozen, for lack of a better word, because there were so many nurses as baby boomers when these women were younger after the war. It was something that they could really do to support themselves, support their families. And nursing has classically been one of those very stable professions for people to go into. So there were a lot of nurses. As these people are aging out, there is this concern that we're not filling the gaps in healthcare, and even with doctors and providers as well, we're not filling these gaps from as the baby boomers retire nearly as quickly because people aren't having as many children. Our country is aging much faster than the number of young people. And while America used to be considered a country of the young, we're now looking more at this as a country of the elderly. So as our labor force in healthcare is decreasing, our patient volume is increasing. Not only because of age, but also because people are living longer and with more comorbidities, so more illnesses and disorders, because there's different treatments available that are allowing people to live with these disabilities and disorders and illnesses. And so there becomes this financial strain on an organization who has less staff and more patients with higher acuity and higher needs. And the question becomes, with limited finances and limited personnel, how do we provide the quality of care to these individuals that they deserve? What can be done to provide quality of care? And where do we draw the line? Where is it appropriate to make cuts financially, or where is it appropriate to say that, okay, we can use somebody with a lower level of education to help fill this role or fill that role? How do we respond in an ethical way that is still providing high quality care at an affordable cost? The other example, which is similar to the topic that I discussed as my personal experience exemplar, is the right of the newly dead. And a topic that's really been coming up more frequently in ethics is not only the duty to respect those who are alive, but to respect those who are newly dead as well. And how are these individuals being treated after death, especially with different views about death and what that means? And is this still a person? Is it a body? Has the soul left the body? What level of respect is required for this individual? There are some places that do have concerns regarding the location of the morgue. And if the morgue is right by the dumpsters, what type of precedence is that setting? And what level of respect is that demonstrating for people? And even the care of the body, the post-mortem care that's done, and how the body is transferred from the room to the morgue. And then there's a question of what to do with the final disposure remains of the unclaimed. And often this is the unclaimed, such as somebody who was maybe in the justice system in prison, who does not have any next of kin, any relatives, a John Doe that nobody can figure out who this person is and nobody has claimed. And sometimes these are even like John Doe individuals that are homeless individuals that die. What do we do with the body? Who is responsible for disposing of the body? How should it be disposed of? Should the body be cremated? Should there be a mass grave, an individual grave? How do we label the grave? What do we do? And then there's also the concern for the respecting the role of the funeral director and recognizing the funeral director as a member of the healthcare team. And this is also another concern that comes up, is this ability to interact and interface between the healthcare team and the funeral director, who many have argued should be part of the healthcare team. So the ethics committee may be working to help with that interaction, because sometimes the funeral director, the local funeral director, is called as a way to push some of these issues off onto that person instead of working collaboratively together. So congratulations, everybody. I am very happy to announce that you have successfully made it through the first half of this course. At this point in time, we have talked about an overview of ethics and bioethics and what bioethics is. We have looked at the foundational theories of bioethics. And then we did a little bit of a wrap-up summary of the theories, discussed where do we go from here. And then in this final lecture, we began to look at how is this relevant to us in practice as healthcare providers or future healthcare providers. I did want to remind you that the information on ethics committees will not be on one of your quizzes. The quizzes are all about ethical theories. However, I wanted you to be aware of this information about ethics committees, because throughout some of these discussion boards, you may be asked to respond as if you were a member of an ethics committee. And that's really not too far-fetched for some of you. Depending on where you take your professional career, having the background and foundation in ethics along with the specialty in your area of expertise may make you a prime candidate to be part of a healthcare ethics committee. And while some of these dilemmas are solved in the immediate setting, as we have discussed, many of these dilemmas that are faced do go to an ethics committee for further review and consideration. So I want to thank you again for all the hard work that you have put into the first half of the class, all the time you have spent taking quizzes, and I hope you are ready to finish up the second half of your reflections assignment. That's really going to give you this strong framework work that will support you as we head into the second half of the course and we begin to actually apply what you have learned to real ethical dilemmas. So take a deep breath. You're halfway there, and I will see you next week.